So back to the part of the eye that very few people are interested in. Don't worry, I don't feel bitter. So I think I spoke a little bit about how we could potentially use the OCT A for the anterior segment, and today I'll be just showing some case examples on how we can use it in a practical sense. So I didn't really have time to go through all that yesterday. So the potential clinical applications could be guiding our treatment. We do perform fine needle diathermy for large feeder vessels and large corneal scars. Anti-VEGF treatment is one option for patients who have extensive vascularization, and many clinical trials show that subconjunctival injections of avastin actually work. We might want to monitor treatment, for example, in a patient with a corneal graft rejection, whether they're responding to treatment, PUK, or steroiditis, as well as treating liver stem cell failure, and a whole lot of other anterior segment pathologies, not just in cornea, but also we're using it to look at pathologies in various forms of glaucoma. So I'll touch a little bit on that. So there's this game called Find the Feeder Vessel. So if you look at the cornea, if you look really, really carefully, you can probably just make out somewhere here, but with the OCT angiography, you can see it very nicely that this is the artery, not the vein, because of the high flow. So this takes 5 seconds, and I have it on my case sheet, and I know straight away where to go when we institute the treatment. And many people have published on how nicely you can achieve closure of the vessel as well as regression of the scar just by this treatment alone. But they often have to use ICG, which is invasive and time-consuming. Here's another patient of mine who came in to me, a 28-year-old female who had previous LASIK and unfortunately had a bacterial keratitis with residual scarring, and as you can see from the top, a very, very faint scar, and can't really see whether there are any, can make out like 1 or 2 vessels, but if you look really, really closely and with the help of the OCT angiography, you can see multiple abnormal corneal vascularizations, and again the on-fast and cross-sectional views actually reveal that the scar is quite deep. It's all the way down to almost 2 decimeters. So she was quite keen for treatment as she was suffering from glare. We treated her with the protocol that's been described is 3 separate injections of subconj avastin, 4 weeks apart. And you can see this is about just 4 weeks after 2 injections, and she wasn't very keen for the 3rd. So we actually noticed quite a big regression in the glare as well as the size of the scar. On the other hand, here's just to highlight the problems with OCT. Here's a 45-year-old male who had recurrent interstitial keratitis for more than 10 years and very, very large residual corneal scarring. As you can see, vision is very bad, involving the visual axis, and you can, without OCT, you can see the large feeder vessel coming in, causing lipid deposition. ICG, very nice, early phase, late phase, and you can actually see the veins coming up, filling up later. And that patient actually fainted when we injected the ICG, and had the resus team come, and everybody's drama. Oh, yeah, and it was just drama. Anyway, but patient's fine in the end, so something well, we didn't have to bag him or anything. But it just reminded me of how annoying for a cornea surgeon to send him for ICG. But anyway, here's a close-up of the ICG, and this question I'll probably pose to the panel. Here's the close-up of that feeder vessel, and on the left, very nice close-up ICGA, and on the right, okay. So this image I took 10 times, right? Like I scanned it again and again and again because I thought it might be an artifact, right? Is it due to a scar? Because this is very, take it from me on a slit lamp, this is actually very superficial. It's not deep, right? So what happened to that vessel? Is it an artifact because of the overlying scar? Is it segmentation, or is it not a segmentation issue? If you believe me, I should put in the segmentation, but the segmentation is very good. I included a very thick layer. The scar is very, very deep. But somehow the vessel here just disappeared and then reappears here. So maybe I can ask the experts. Maybe start with Michael. What do you think?
Is it just in front of the lamppost?
No, this is no.
No.
It's quite far down. If I give you the big picture, I was just blowing up. It's just here. Yeah, I was just blowing up this part. Because no matter how I scan, I had large scans and then 3x3 scans and 6x6 scans. They were all quite nice. But whenever I did the 3x3 scan, just here, right? And I'm sorry, I should have put in the segmentation, but segmentation was fine. All layers were included. What do you think? Yes?
I think 3x3 is more sensitive to the micro movement or...
Oh, I did this. Micro movements. Okay, so these are the micro artifacts. And I did this. This is like my best quality image. I did it again and again because I thought, can't be, right? I can't publish this. So nice, right? It's so juicy. And this patient, I actually submitted to another. We did diathermy, just one buzz. Took me like 2 seconds. It was all gone. So I have another image which I didn't show here. I think. Oh, I do. I'm going to show it here. The next slide where it's gone. But I just wanted to find out what Giovanni, what do you think? I know this is far away from the retina, but
some leakage over there, but
it's not a scar.
No scar.
It's very superficial.
Could it be too fast or too slow?
Yeah, okay, so basically, this was what we discussed in our paper in ophthalmology. Is it low flow, so it's below threshold? Or, what I had to go and dig, and I emailed David Wong about this, but nobody replied. But anyway, so basically what happens is that the SSADA, right, compensates the algorithm, according to the paper, the original paper, compensates by increasing the transverse signals. That means any flow that's going transverse, because all the retinal vessels only go this way. Hardly any vessels come axially towards you. So the algorithm compensates by increasing anything that's transverse in sacrificing any axial. So if the vessel comes down this way towards you slightly and then goes down again, or loops upwards towards you, then you lose some signal. So that's one of the, we were discussing in the paper, but I just wanted to open. It looks like nobody has the answer. But we scanned this patient a lot of times, and fortunately he didn't faint from the scan. He fainted from the ICG. So here's the patient. Yeah. So we buzzed this, and this was the post-op day 1. But eventually, we take it from me, it cleared up completely, and you can see the regression of the vessel. So this is motion artifact. So this is very hard to get rid of, right? But not the best images.
Can I ask a question about that one? So if you think it's axial movement, right? Clinically, does a vessel have that kind of force, or
it's hard. I tried to look at it. It's not something that's coming towards you directly, but it changes sort of direction, not in this plane. It sort of like comes from deep and then superficial. Then you would argue, why can't you pick it up with the segmentation? Because then the superficial segmentation should show it, and then the deep. But somehow, when I took all the layers together, just couldn't get that vessel. It's just a missing segment. Every time I could show you 20 images, same images, and I just couldn't get that segment of vessel. Very strange. But it could be low flow. It could be really low flow. And
why low flow and then it became fast?
Yeah. So the issues with the perils of OCT and
you don't have a angiogram scan in that
we did. I didn't include it, but it wasn't. It didn't give us more information. I mean, it was flow. There was flow there.
It was flow.
Yeah, absolutely. It was red. I don't know. Anyway, just something to keep in mind. So here's a patient with corneal graft vascularization. We published on this, and you can see not so clear on the slit lamp examination of the red free, but from the OCT angiography you can see the vessels quite clearly. And here's a patient with acute graft rejection, and you can see all the really engorged vessels which go away kind of go away with treatment. The eye turns quiet and the vessels go away. Okay, last case that might interest some of you, not just in the anterior segment. So here's a 54-year-old gentleman, history of hypertension and diabetes, and a chronically red left eye and double vision. Differentials, anyone? Just red comes in, my eye has been red for 6 months, no pain, but double vision.
No pain.
A bit more information, vision in the right eye, left RAPD, left reduced color, and high vision. So look at the eye. Yeah, absolutely. So we all know that the presumed, so I looked this up actually, it's quite interesting. A lot of talk about the presumed mechanism for raised IOP in CCM, but nobody actually proven it. Right? It's because of the increased episcleral venous pressure. So very nicely, the OCT is able to show the episcleral venous layer, and you notice that the vessels run radially in the episcleral venous plexus, as opposed to, circumferentially, as opposed to radially, which are the limbal and episcleral limbovasculature, or the marginal corneal arcades, which I showed you yesterday. So here's some other images in other quadrants, and here just to show you the segmentation. The superficial radial vessels are the limbal vessels or conjunctival episcleral vessels, and then the deeper episcleral venous plexus, and then deeper the normal vessels. And just for fun, I did the OCT A because the pressure was high, and there was some, so this is Michael's area, some early loss, but we don't really know much at this stage. So yeah, pretty fun stuff for the anterior segment, may be able to help us in our daily practice and hopefully extend that. We're looking at the effect of glaucoma and glaucoma filtration surgery in the anterior segment as well. And we also have a series of sternitis and PUK patients that we're going to publish on, but we don't really have time to. Same people I want to acknowledge. Any questions?
Any questions?
Just like yesterday. All right, thanks very much.